That's a PDF, so it's not that one. Except for PDF was the printout. Hello. Good. Okay, well, thank you, Juan, for this invitation, and it's good to be here. And I was given the task of talking about principles in management of the ocular inflammatory diseases. So I'm gonna just this is kind of a generalization, obviously, and we'll go from there. And so just take about uveitis, for example. This is not a new condition. It's been around, right? And have anybody been studied Egyptian arts? If you look at the drawings or paintings or sculpture, the eyes are always very detailed, more so than most other arts. And maybe because of that, they've noticed uveitis back in ancient Egypt. And back then, the treatment, they actually had a treatment. It's been described as using a compress that's soaked in a lotion made from saltpeter and wood shavings. And then you fast forward about 3,500 years, and the treatment at that in the early 1800s is bloodletting and leaching. So, well, there's some principle in that. They recognize that blood contains some sort of mechanism that is inducing the uveitis and therefore drain it. So if you don't have the immune system attacking the eye, perhaps it made it better. And fortunately, we don't live in that time, and so we don't have to do these things in the clinic. And in the early 1900s, the treatment is based on more directed to kind of alter the immune system in a slightly different way. So people were injecting antigens, typhoid antigen to milk, to various things into the muscle. So then your immune system responds to that. So maybe it'll forget about the eye for a little while. In 1950, that's when corticosteroid became available. Its effectiveness in uveitis is instantly recognized in the form of drops, in the form of pills, and also intravenously. So since that time, we've also recognized that there are detrimental effects of chronic steroid use, and we're looking for various other ways to treat uveitis, to minimize some of these steroid risks. And I was a resident, where you guys in your career about a little over 20 years ago. So at that time, there are few uveitis mavens in U.S. and they were talking about what to do for chronic uveitis, Dr. Foster, Dr. Jabs. But in most residency programs, they didn't have uveitis program, and mine didn't. And the principle at that time for me was steroid, steroid, and more steroid until everything's quiet. And then keep them on steroid. That was the principle, but that has fortunately changed since that time. So with the current standard, treatment standard, we treat non-infectious uveitis with local, topical, regional, oral steroids in combination with the use of immunomodulatory therapy. And there are certain guidelines how we should approach this. And this was actually a standard that was set up back in 2000, shortly after I was a resident. But still, from that point, we all recognized that changing the pattern how ophthalmologists practice is, or doctors in general, it's a bit of a challenge. And so much so that in 2015, this is a publication for 2015, I also worked for an organization called Ocular Immunology Uveitis Foundation. I'm a board member. We organize educational events, and this is the publication we put forth on the principles of managing uveitis. And in it, the basic concept is that steroid is used for acute setting, and if you need a chronic treatment, you have this stepladder approach that starts with medication that's the best tolerated, easily tolerated, to as a stepladder to the next level, which requires more monitoring, and then the step beyond that is medication that has no proven track record, and then the ones that are more potentially toxic and so forth. So it's the stepladder approach that is basically the principle that most uveitis specialists these days stand by. And so the first thing that we know, I mentioned, was the steroid. And most of the steroids have the FDA approval to treatment of ocular inflammation. And these are the steroids that are available in US as a topical steroid. Actually, I don't know if the betamethasone is available anymore, but I know in many other countries it is. Regional steroid, triamcinolone is used frequently, dexamethasone is used frequently, and now we have fluocinolone, which is, there are 3 versions of intraocular implant now. The UTIQ, the Illuvian, and the older one is the Retisert. All these are considered regional steroid, and then you have your systemic steroids. The limitation of the steroid therapy, that it is a temporary bandage in a way. It addresses the inflammation fairly quickly, but then once you withdraw the steroid in the chronic cases or the recurrent cases, the condition will return. And it also contains a large list of side effects. And topical steroids, we will know that chronic usage leads to glaucoma and cataract. And in a periocular steroid, the injection is not always benign. This is a picture of someone who had parsoninitis with the 20/20 eye, but you see the white needle track that went through the globe during periocular injection of triamcinolone. And also periocular steroid given repeatedly causes glaucoma and cataract. Intraocular steroids, intraocular side effects may include retinal detachment from injection injury, glaucoma, and cataract as well. Systemic steroids can cause glaucoma and cataract. Patients with asthma and chronic steroid therapy, they have PSC cataracts. They may have impaired wound healing for ocular surgery, and they're more susceptible to infection. Myopia has been reported as a potential side effect of systemic steroids, the pseudotumor and central serous retinopathy. And here's a list of complications of systemic steroids. And as you well know, this is the partial list. If you want the whole list, it will not possibly fit in here. I just want to mention briefly about MUST trial, which is the multicenter uveitis steroid treatment trial, where the comparison was done for patients' outcome and in using the Retisert implant versus systemic immunomodulation. And this is a large-scale study sponsored by NIH and NEI that looked into anything from the visual outcome, the frequency of surgery that's needed, and to their lifestyle in the end. In each of the treatment group, there were, whether it's systemic immunomodulation or Retisert, the vision improved on these patients, and they were about equivalent. And the systemic therapy also was well tolerated. The Retisert group tend to have less systemic complications, but then the Retisert group certainly had more chance of glaucoma surgery and cataract surgery. In fact, 80% of these patients had required a cataract surgery during the study period. So corticosteroids for ocular inflammatory disease is suitable for acute flares as an adjunct in low doses. In generally, that's not how we like to use it, but on a rare occasion we may have to. And you treat acute cases with high dose initially, and then try to taper off as quickly as possible. And regional steroids, fortunately, when it's given this way, may have less systemic side effect compared to the systemic steroids. Now, moving beyond the steroid, once you have established, someone asked earlier a question about when you consider a failure, 3 months. If somebody's steroid dependent on controlling their inflammation, sometimes inflammation may be controlled with their steroid early on, but every time you taper it off, it just can't. It keeps coming back. The steroid dependence is also another reason for concern. So therefore, once you recognize that, you should move on. And so now the principle of the step ladder is that you approach it this way, but your goal is no inflammation and no steroid. Those are your 2 goals, okay? And NSAID, oral NSAID, is a good starting point for, say, HLA-B27 associated recurring anterior uveitis. These are the oral NSAIDs that's available in the U.S. And we keep patients on this for 2 years. There's no set time. This number comes from, the 2-year mark comes from our rheumatologist colleague mentions about this 2 years. There's no real magic to it. I also saw an ARVO poster a while back, I don't think it was ever published, comparing the frequency of a flare-up after you stop treating with the systemic immunomodulator. After 1 year of quiescence, after 2 years of quiescence, after 3 years of quiescence. So the poster mentioned that after 1 year of quiescence, you stop the medication, there's about 70% chance the disease recurs within the first year. This is like a general, very general assay of various conditions with the various form of treatment. So it's not exactly controlling in that fashion, but it showed that after 1 year, 70% recurred within the first year. After 2 years of quiescence, about 50% of patients did not recur, or 50% recurred within the first year. And after 3 years of controlling, only slightly above 50%. So therefore, that 22 years is kind of a sweet spot, so to speak, for how long to keep these patients controlled before people attempting to try to stop. But there's no, every patient is different. There may be a reason for you to stop sooner than later. And then there are conditions such, say, sympathetic ophthalmia. They will remain on immunomodulation, most likely for the rest of their life. Okay? So there are conditions that certainly requires longer duration of treatment than others. And after NSAIDs, so let's say a patient with HLA-27, and you put them on an NSAID, it doesn't control it. So the patient was on topical steroids, everything is quiet, but every time you try to come off, it flares. You put them on NSAID, and you taper the steroid. If it comes off the steroid and the eye's quiet, you keep going for 2 years. That's your basics. Okay. Let's say the NSAID, you start the NSAIDs, first 3 months, great, off steroids. Month 4, all of a sudden there's a flare again. What do? You go to the next step. Okay. You go to the next step. The next step generally is considered, and then the steps are changing a little bit as we go. Mostly because it's actually surprisingly how active the pharmaceutical field is for uveitis. There are quite a few interests in this, and besides your methotrexate, we have far more options, and then this paradigm may change slightly over time. But as of now, antimetabolites are our next step. Generally, I go with methotrexate if there's no contraindication, if there's no liver problem, and the patient is not a drinker. Azathioprine, mycophenolate, these are all considered within this group of next step ladder. It is rare for me to use Aracy. I don't know the last time I used that since fellowship, but just certain things I just don't use. Even azathioprine is not my favorite. I think methotrexate does better with the fewer side effects. And then you have your the next step. The slightly different category is calcineurin inhibitors such as cyclosporin, tacrolimus, sirolimus, all in this category. And then you have your biologic. This is the field that kind of really exploded in the last 10 to 15 years. And this is not meant for you to be able to read this. This is a page from the paper I mentioned about on the survey ophthalmology. But this was the list back in 2015, and now the list is even bigger. Just to summarize the list, in terms of the biologic, the whole category of medications where you have a very targeted, you have a molecule that targets a very particular part of your inflammatory response, a cytokine, an interleukin. Okay, so we're understanding as we're beginning to understand how these things work, and some of them work quite well. The TNF-alpha inhibitor was the first set of biologic that came out, etanercept to infliximab, then followed by adalimumab. And now, in addition to that, we have some data in tocilizumab, the interleukin-6 inhibitor, and rituximab has been also being used widely. Rituximab is just expensive, but it's one of those things that comes to the rescue when everything else fails, and you use it, and it depends on the condition it may respond. You have the interleukin-1 inhibitor, jevacizumab. It's left in there, but that was this is a slide from once upon a time where jevacizumab was in trial, and that the clinical trial failed actually, so it's presumably gone. To many others. And before the biologics, when your non-steroid therapy failed, we were contemplating using things like cyclophosphamide, chlorambucil. These are actual cytotoxic agents. Chlorambucil, there's been report that it can cure uveitis. You wipe out the immune system, then you do a bone marrow transplant. Yes, you cure uveitis. but at a cost. In US, the two FDA-approved non-steroidal treatment is Humira and Ocular gel. That's it. Methotrexate is not, mycophenolate is not, cyclosporin is not. Okay? That's a completely separate topic in that what does it take to get FDA approval and what does it mean to have a FDA approval? That's a whole separate categories. But for now, this is what we have FDA approved in US. So adalimumab, Humira is an adalimumab that is marketed in US by AbbVie. And it's a humanized monoclonal antibody against TNF-alpha. And it got its FDA approval treatment of posterior uveitis in 2016. And other indications are rheumatoid arthritis, GRA, Crohn's, psoriasis, just to name a few. They really went out of their way to get as many indications as possible. In general, it's contraindicating patients with MS and TB. It's missing a thing over there, but this is one of the two paper that came out in 2016 where Quan and I were both involved for the data that was submitted to the FDA for the FDA approval for adalimumab. Ocular gel. So I do not believe this is available outside the U.S. So I don't know if you know this at all. This is a naturally occurring ACTH, and it is given twice weekly, but that dosing is pretty much random. It is its mechanism of action. So it is ACTH. So if you remember from the medical school days, the first year of medical school, ACTH produced by pituitary glands, stimulates the adrenals, produce cortisol. The mechanism of how it actually helps inflammation or reduce inflammation in uveitis is actually not known. There may be alternative pathway besides the corticosteroid inducing pathway, such as non-important receptor pathway, but those are things that we're actually discussing now and studying now to understand further why this medication helps or it helps. It was approved by FDA in 1950. It's being shelved for the uveitis public until very recently, and now there are several ongoing prospective studies looking into uveitis, sarcoid, scleritis, and retinal vasculitis. Let's skip that one. Okay, and then there are, so those are the two that are FDA approved, and there are many ongoing trials, and some of them have active in the phase 3 trial part, so they may come into market within the next 5 to 10 years. And then there are many medication with a partial data, but we use it. We use it when we need to, and the difficulty is trying to get the insurance in U.S. is trying to get the insurance company to approve for us to use it as an off-label medication. At least in our country, that's possible at times. I know there are places where they just will not allow you to use tocilizumab to treat uveitis. So why do we do this? The principle of managing uveitis: no steroid, no inflammation, no steroid. Does that help a person? How does it help a person? Do they have a better outcome in the end? Okay. Some of these questions we try to ask with this study that I'm putting up here that I was a part of, looking into the healthcare cost of uveitis care. So we decided to study this using insurance data on their diagnosis code to how money they paid out for to the pharmacy, to the emergency room, and to do surgery. So what we did was we searched over 80 million data points on those patients who had uveitis, anterior, posterior, intermediate, retinal vasculitis. We just wanted to kind of get a sense of a larger picture of how, people are treating uveitis and whether there's actually some sort of tangible data we can say that this actually helps patients in some way. So we divided these patients we gathered all the uveitis patients in this data set, divided them into patients who receive only steroids, and then that's one group, and then the patient with the IMS group is a patient who had received immunomodulator, non-biologics, so methotrexate, cyclosporine, mycophenolate, all fit into that category, and the biologics, so the three groups. And we followed their monthly cost, basically, of what the insurance company had paid out for their care. And so we looked at before their diagnosis of uveitis, and then we looked at after their diagnosis and after initiating the medication for that uveitis. So for example, this one says, is there a major? Yeah, okay, got it. So on a monthly basis, before the baseline, they're in the for example, the corticosteroid group, the baseline monthly for all healthcare costs. It is not just the eye care. This is their if they have diabetes to high blood pressure. The monthly cost is on average is $717 to patients who have, and then, let's see. And so we looked at these medical costs on a inpatient stay, how often they stay in the hospital, and the emergency room visits, okay? And to the outpatient cost on their care in the three different groups. So before the medications versus after starting the steroid or methotrexate or infliximab, their frequency of inpatient stay in the hospital goes up for patients with steroids. Patients with immunomodulator, it's in about the same, maybe go up a little bit. And patients who receive the biologics, their frequency of hospital stay actually went down. And their emergency room visits also increased with among patients who are receiving only steroids. The other group has a reduction in the ER visits on a monthly basis after starting those category of medications. And with the total monthly inpatient cost of the patient, for the patient, you also see reduction among patients who received the immunomodulator or the biologics. But the total monthly direct healthcare cost was the one in biologic patients that went up significantly after starting the medication. But this is a direct healthcare cost, so it includes everything. So if you take away the medication costs, then you see the significant drop in their monthly cost of care. Now, this is, granted, this is a very loose data, but what we're trying to show is this. If somebody had uveitis and being treated with the biologics, and if their health is better, so they don't need the cataract surgery or glaucoma surgery or any other surgery, would that reduce the healthcare to suggest that. And to me, this is like a way to kind of validate what we do. What we do with giving patients methotrexate for 2 years. Why does that help, right? This is an evidence to suggest that. So, in conclusion, uveitis remains a challenging condition to treat, and we have various options nowadays to treat medications and to treat uveitis, and then we still need more what we call FDA-approved treatment in U.S. because that allows us to be more flexible and have choices for patients, because not everybody will respond to adalimumab and may not be ideal treatment for certain patients. And cost of uveitis is one of my interests as well, and I feel that there needs to be more studies in this area